Hello, everybody. We're just checking sound here, and we'll be ready to start now in a few moments. Okay, hello, everybody, and welcome to QI Talk Time. My name is Siobhan Reynolds, and I'm standing in for your usual Talk Time host, Roisin Breen, who is about to go on maternity leave. So congrats to Roisin. Myself and Noemi will be looking after Talk Time while Roisin is away. And many thanks to Noemi for managing the technical pieces in the background and making everything run so smoothly each month. This is our third Talk Time since September, and I'm delighted to introduce Dr. David Weeklam today. David's webinar is about HSE partnerships for quality of care in Africa, maintaining essential services and improving quality during the pandemic. Dr. David Weeklam is a director of the HSE Global Health Programme and is also a member and a colleague of mine in the National Quality Improvement Team. He's a specialist in public health medicine, and he's worked in global health for over 30 years. From 2003 to 2007, he was the health advisor with Irish Aid and the government overseas aid programme, and he's been leading the global health programme since 2010. David manages a number of bilateral programmes with ministries of health in Mozambique, Ethiopia, Sudan and Zambia, and he also leads the Esther Ireland programme. Before we hear from David, there are just a number of housekeeping issues that I just want to remind you of. For those of you that are dialing in, the telephone number is there, and if you have any problems with sound, you can dial in or you can use your computer, and there's the access code. The chat box function will be active, and what we'll do is we'll keep an eye on it during David's presentation. And any comments, questions for David, we can share with him at the end of his presentation. And if you wouldn't mind just using the everyone function when selecting to share your comment with everyone. So feel free to add your questions and comments. And we're hoping this QI Talk Time will be as interactive as possible. And just to note, we'll also be recording this Talk Time, and we'll share the slides on the National Quality Improvement Team website. So I'll hand over now to David to share with us his presentation. Thanks, David.
Yeah, thank you, Siobhan. Thanks for the invitation to speak this afternoon, and good afternoon to everybody. I'm delighted to have the opportunity to share about some of the work that we're doing. I think you've introduced what my role is in that. So the presentation is going to really have two parts to it. In the first part, I'm going to talk generally about the work we're doing with other countries, low-income countries, particularly in relation to improving quality of care. I'll say something about why we're working in Africa and the approach that we take in our work with our partners. And then the second part is really about what we've been doing the last number of months since the pandemic started, how we've worked with our partners in responding to COVID-19, how this has affected our QI programs, how we've continued them, and then towards the end, some of the lessons that we have learned over the last number of months. So the first question, and one you may well ask, is why are we working in Africa in the first place, when our health service has a mandate to provide health and social care in Ireland? And I think first and foremost, it's not about working with other countries, it's about how we think about health and healthcare. And today, all the health issues that we deal with have a global dimension. And it's really recognizing that health these days is global. And so global health is about recognizing that health and health issues are transnational. And so it's in all of our interest among different countries to work together to improve health and to achieve equity in health everywhere. So the first reason for working with other countries and low-income countries is that it benefits our own health service. And we need to work together with other countries if we're going to deliver high quality healthcare and protect our health here in Ireland. And in my view, that's not just high income and well-developed countries, it includes less developed countries. And I think if there's one thing that the COVID-19 has shown us is just how much we're all in this together when it comes to addressing some global health challenges. And COVID-19 it's a global outbreak, it's a threat to our health security, and what happens in other countries affects our health here. And it's been the same in the past with Ebola and other outbreaks, and we could talk about other health issues as well. But additionally, as well as this needing a collaborative approach to addressing global health issues, we also can learn from other organizations in other countries. And I've shown a couple of pictures there from a visit to one of our partners in Ethiopia. And Ethiopia is in stark contrast to Ireland in terms of the level of resources it has for its health system. It is a tiny amount of resources for a population of over 100 million people. And yet they've made remarkable improvements in their health status over the last number of years. And one of the things we observed in a visit, and there's a picture of a clinic that you can see there, one of the primary healthcare clinics that we were brought to, is we learned how much the improvements in their health has come about because of their strong primary healthcare approach. And inside the clinic, vast amount of information about all of the households in their catchment area. So every household was visited within every quarter. They had data about every household, about its water supply, its sanitation, about immunization coverage, about diseases and so on. So there's lots we can learn from other countries. And it's also very good for our own staff. And I think anybody who's been involved with working with some of these other countries will say how much they have learned and benefit themselves. And this is learning that people bring back into their jobs here in Ireland. So in addition then to benefits to our own health service, we certainly have something that we can contribute by being a global health service to health in other countries. And I like to show this slide, which just highlights the contrast across the world in health needs and health resources. And here you see a picture of where the burden of disease is for HIV in the world. And it's mainly in Africa. And this will be the same for other diseases, the same kind of picture. So you would think, well, then, of course, this is where resources in the world should be concentrated. But where are the health resources in the world? And as one example, the resources of health workers and health professionals. And this map shows that they are in everywhere except where they're most needed. There's a big, huge mismatch between health needs and health resources. And so we're part of this in Ireland. We're part of this global problem and challenge of inequality. And so it makes sense that we should act in global solidarity with countries with greater health needs. Now, these are the Sustainable Development Goals posted up on the first floor of the HSE headquarters in Dr. Stephen's Hospital. Now, they're not there at the moment because they're painting the walls. I hope they put them back again, because I think these are important to show that we have a role. The health service, our health service, has a role to play with improving health in less developed countries. And it's part of Ireland's commitment to the UN Sustainable Development Goals. Goal number 3 is good health, ensure healthy lives and promote well-being for all at all ages. That's a goal for us here in Ireland. So we strive to achieve that through our health service. It's also a goal for the world that we're part of contributing to. And the Sustainable Development Goals also tell us something about how we're going to achieve that. And Goal 17 is very important for us because it talks about the how, the part which is about partnerships for the goals. And it challenges countries everywhere to work together, to cooperate, to achieving better health for everyone. And so partnership is a very important aspect of the way we work with other countries. And for us, partnership is very much about equality. It's not about us as the experts going in and telling others how to do things. We have similar problems, similar challenges. We work together as equal partners. And partnership is about commitment. It's about having some shared goals and objectives. And it's about taking a long-term approach to working together to achieve better health. And this approach of partnership is one it's echoed by our partners in other countries. This is a quote from Dr. Elenia Amado in Mozambique, one of our key partners. And they will keep reminding us of how helpful the partnership between our health service and their health service is for them to improve quality in their health services. So this is key in the way we work. And across the health service, we see lots of different partnerships. Some we manage through the Global Health Programme, partnering with health services in other countries. But we see across the country, hospitals, primary care services, GP surgeries, public health departments, and so on, having links with other countries where they work together as partners to improve health and healthcare. So I'm going to focus on some of our programs that we manage, our relationships with health services in other countries. There's 4 particular countries that we work closely with: Mozambique, Zambia, Sudan, and Ethiopia. I'm going to talk particularly about the quality improvement work we're doing, which is particularly in Mozambique and Ethiopia. And Mozambique, which is as an example of the work that we're doing, it's our longest standing relationship. And here you see Philip Crowley, the National Director for Quality Improvement, signed the agreement with the government of Mozambique back in 2014. So this is a partnership model. The Ministry of Health is very much in charge. It's their programme. Work the partners in the HSE. We are delighted to also have as another technical partner ISQA, and the CEO of ISQA, Peter Lachman, very involved with the programme. And on the ground, it's the Irish government, the Irish Embassy. And it's this close partnership, which is in reality a very close working together of all partners, is what makes this work. And this photo is from one of the visits, highlights this, where you can see the Minister for Health, the Ambassador of the Embassy, Philip Crowley, Director of Quality Improvement in the HSE, Peter Lachman from ISQA, and also the Dr. Hussain, the National Director for the Health Services. So this is very, very practical collaboration. And what do we bring from the health service? Well, we bring our experience in addressing quality issues. We have similar challenges. We can share that experience. And we have our learning. We have our own framework, our own approaches. So that's what we bring, our learning, our expertise that we can share, and we can work together with them as they work through the similar issues. And Mozambique is a very challenging country to work with. And this is just briefly give you a flavour of the country. It's a large country, population over 30 million. The health statistics are not good: high child mortality, high maternal mortality. And if you look at the bottom there, total expenditure on healthcare, it's very low. It's less than 2% per capita of what we have to spend in Ireland. And yet with that, they've got to address huge health needs. And if you travel around the country, you'll see a very basic health service. This is a typical clinic serving a population of maybe over 10,000 people within 30 kilometres. And you go inside and you see very basic facilities, one trained staff. The table there is an upturned cardboard box that the medicines came in. They have a fridge in the corner which works and has some vaccines, with very, very few supplies. But this is the context within which they're trying to improve quality of their services. So our program, our technical program working on quality, took off in 2016 when the director in the Ministry of Health in charge of hospitals came to us and said that they would like to work on improving quality. That was their concern. And that was really critical because that was their decision that this was what they wanted to work on. And so we undertook a program, collaboration with them, to a series of workshops over 8 months with teams from 14 hospitals and from the Ministry of Health, going through a program very similar to what people in Ireland would go through for learning about quality improvement. And each hospital then undertook a project. They identified a quality issue in their hospital that they wanted to address. I'll give you a flavour of some of these. And what you'll see as I go through them is very similar to the kinds of issues we'll be addressing here in Ireland. One example, the Jose Macamo General Hospital, they were very concerned about the problem of high mortality in the medical ward, particularly within the first 24 hours. People, very sick patients, many of them were dying. And they managed through their project to reduce the mortality from 11 a month to 4 a month. How do they do it? Well, we introduced them to an Australian methodology, between the flags. So a methodology for monitoring the very sick patients and detecting when patients were deteriorating. We got permission from Australia to translate this into Portuguese, and we support them to produce copies of this, and now this is being used in the hospital and has been used since. Another example, the Matalani General Hospital, they're concerned about waiting times, gynecology waiting times, 60 days. And through their project, they reduced that to 30 days. And what we saw and observed is as they trained and learned, as they started to train others in the hospital, they shared the information then with other hospitals. And we saw that they were improving their referral information. And visiting the hospitals, we could see the methods that they were using, that they were learning and applying the methods, quality improvement methods very effectively. Another one, in Fulani's psychiatric hospital, they were concerned about patients absconding and they wanted to reduce that. And that might seem a strange one to address, but that was their priority. So that was important to work with them on that. And a lot of their patients are people who have drug addiction. So it was quite difficult sometimes to keep them in the hospital. But what we observed coming back some time later was that the person in the middle there, Dr. Serena, she's the senior doctor in the hospital, she had initiated quality improvement training for the entire hospital. So they were all learning about quality improvement, and they were undertaking new projects. Matola Provincial Hospital, another one where waiting times was the issue, emergency department waiting times. This is a very common problem there, just as it is here. And they succeeded in reducing waiting times from 5 hours to 3 hours. One of the remote hospitals, Nampula, their issue is a different one. They were concerned about the quality of medical records on the wards, and their project led to improvement of the records. Another one of the rural hospitals, Beira Provincial Hospital, looked at improving communication with patients. One of the things that has struck us in our work with Mozambique and similarly with Ethiopia is they have a strong focus on the patient. They're quite patient-centred, they're quite person-centred, and I think that's something that we get learning from for ourselves here. So having trained teams, then the next thing was how to build on the training, follow up of coaching and monitoring and further training and training of trainers. And the key person is in the picture on the right, Dr. Elania, who I referred to earlier, who's in charge of the hospitals, the key person on the ground, regularly visiting and monitoring the hospitals. That's the most important aspect of their quality improvement program, is having that support from the Ministry of Health. Our role is secondary to that, but also we have a contribution. So that involves when we visit, maybe once a year, maybe twice a year, that we go and we visit the hospitals and have coaching visits in the hospitals. But a lot of it is remote, and we're long distance from Mozambique, so we've been relying for the last couple of years on remote methods, Zoom calls, doing coaching by Zoom. And we've seen that can work very effectively. And countries like Mozambique and Ethiopia, they've got reasonable internet coverage, and this works very well. So building on the work of the hospitals, our challenge is how can we work with the ministry there to build capacity for the country in quality. So building capacity at the national level so they can lead and manage improving quality across the country. And we were pleased that one of the results of the work we've done with them was the government taking more notice and giving more attention to quality and establishing a directorate for quality and standards in the Ministry of Health. And we took the opportunity with that too, to work with the ministry to run a workshop to assist them in developing their national quality framework. And what you see there is something from the WHO National Quality Policy and Strategy Handbook, which was being developed at the time. And we took advantage of that in working with them. So this is about building up capacity in the national level that can sustain what they're doing across the country. And undertaking new initiatives. This was one in 2017, and you see in the picture one of our team, Lorraine Murphy, training on prevention of pressure ulcers. And initially, when they asked about doing it, I was very reluctant because I thought that they were interested in that, in part because they'd seen on a visit to Ireland what we did here, and that maybe it wasn't their priority. But they decided this is what they wanted to do. So we provided training with 5 hospitals. And they now have quality improvement projects in 5 hospitals improving pressure ulcers. We broadened the collaboration. We're a long way from Mozambique here in Ireland, so we sought to develop links with more local partners. This is from the Aurum Institute in South Africa. And we were particularly attracted to them because they have a very, very nice how-to guide for quality improvement. And we got permission from them to translate that into Portuguese. And now that's available for the health services in Mozambique. So what have we achieved by 2020? We were back last in February, just some time before the pandemic, and we had a chance to hear what progress they were making and whether it was being sustained. And we haven't been out for well over a year, so it was really a good chance to see how things were going. And we visited a couple of the hospitals, and these are good examples of evidence that improvement is being sustained. This is the Mozambique Hospital, where they were concerned about the high mortality in the medical ward. 2017, they had 58 deaths in the year on the ward. That in 2019 was down to 8 deaths. So we saw the evidence that the results are being improved, that the improved outcome is being sustained. The Matalani General Hospital, here was the gynecology waiting times. That was the problem. And they'd reduced that to 30 days. And when we were there, they said, oh, we reduced it to 20 days. But what we discovered when we visited, it wasn't just that they'd reduced it to 20 days for the first visit, they had reduced to 20 days for the first 2 visits. And so they've really made a lot of progress. And they were applying that same approach then to waiting times in other wards. And the pressure ulcers, we saw that continuing to improve there. And I showed this one because it just reminded me, this person here, Helena, is one of the leaders in the hospitals. And what's been so important is to find the people to work with who are the leaders in the hospitals, the leaders in the ministry, who are going to lead the change in quality. And we've working with some wonderful people, and it's a credit to them that a lot of the changes have taken place. At the national level, we see the progress, the established directors in the ministry. We see regular monitoring, coaching by the Ministry of Health, and they're undertaking new projects and spreading these across the country. So in summary of the progress, I'd say we're seeing there's evidence of impact in Mozambique with quality projects. It's becoming more sustainable in the hospitals, in the Ministry of Health, the key institutional structures being established. We're seeing new quality initiatives in response to needs, and that's demonstrating that they have developed capacity to be able to respond to different priorities as they emerge. And we would conclude that the way we work between Ireland and Mozambique is an effective and efficient model for technical cooperation for improving quality of care. So I want to move on now to talk about COVID-19. What's happened since the pandemic started and how have we responded? And first and foremost, it's been about showing solidarity. Partnership, I've emphasized that at the beginning. We work in partnership, and partnership is about commitment. And that's commitment in good times and in difficult times. And so it's been really important for us that at a time of crisis for us and for them, that we don't move away and we just focus on our own challenges. So the pandemic is a threat to all we've been doing with them. And so we've made every effort to continue to work with them. And just a couple of quotes there that you probably hear often enough. We're only as strong as the weakest link. None of us are safe until all of us are safe. And I've been using these quite a bit to remind people that actually at a time like this is a time we need to stay together working with our partners in our own interest as well as in their interest, because this pandemic is something we need to address together. So we've continued to work, but that's not been easy. Many of our global health program team were redeployed to the national COVID response. So our team is depleted. Similarly, our partners, they've been taken up in their countries with the pandemic response. And add to that, we can't travel, so it's not easy. But what's been key, I think, in this is that we've had the support of senior management to continue the work. And so even in a different way, we've been able to do that. I think what's important as in the way we've responded is it's not just about responding to COVID-19. The reason we work with these countries is because we're trying to work with them to develop and bring about sustainable improvements in their health services and health systems. That's still the goal. COVID-19 it's a crisis that's sort of come in the midst of that. But of course, these countries will experience many crises, frequent crises. Mozambique has had cyclones and floods and all sorts of crises. So we need to keep our minds on the longer term objectives. So we have the immediate challenges of how to work with these countries to control the virus, how to maintain essential services, which, as in Ireland, where we're disrupted, how to protect health workers. That was a big concern. And longer term, how do we keep the focus on building and strengthening health systems? And how do we help the health systems to become more resilient? after the pandemic. So what we've done is we've continued to work on the QI initiatives. We've kept that focus while at the same time providing some support for COVID-19. So we've been providing technical advice, sharing information and resources, running learning and networking events, developing training materials, and working across the health service with other different parts of the health service so that they can continue their partnerships and supporting their partners through the pandemic. And we've also worked closely with the Department of Foreign Affairs, who are a key partner. We have a memorandum of understanding between the HSE and Irish Aid. So at this time, this is a very important relationship. So we are in the early days of the pandemic, we're providing technical advice. We were some bit ahead of them, of African countries with the pandemic. So we were learning a little bit quicker because of that, and we could share some of that learning. And that's continued maybe in a different way, where they continue to have from time to time different issues in relation to COVID-19. We participated in the Interdepartmental Committee, the government's Interdepartmental Committee on Development Cooperation, and being able to share and contribute about what we've been doing with COVID-19. And more recently, the Development Minister, Colin Brophy, has started a new initiative on mental health for health workers, to support health workers in the pandemic. And we're going to be implementing that initiative in Ethiopia. So with Mozambique, we've continued our QI training, capacity building, of course, all online, and that's worked well. And I just put up this picture to show there's a person on the top there from Portugal, Paulo Sousa, and he's joined our team, and this has been really valuable for us because many people that we work with in Mozambique don't speak English, and that becomes a real challenge when you're running webinars. And so to be able to bring in a global QI expert who's Portuguese speaking has really enhanced our way of working online. So that's been very good for us. We've continued to work with the ministry around their work to improve, to maintain essential services. That's as much for them a priority as the pandemic. And that's been a focus of a lot of the coaching, to continue the services and improving quality of existing services. And then we've provided support and advice as around COVID-19, and that's sort of become integrated into some of the learning for QI. And it's been great to observe the hospitals continue to initiate new projects and to support them in that, even at a distance. So this is an example, the Matalani hospital, which I referred to earlier, they picked up from that, the community level, that older people were not finding it easy to access the services. And many older people with chronic diseases weren't coming into the hospital because they perceived quality of care to be poor, or their experience of the care was poor. And so they undertook a project to address that. And this is from a presentation they made on one of the webinars just in the last month. And it was very nice to see them applying the QI methods, doing the good analysis. Here's the driver diagram. And they'd done a survey of the community, of older people in the community, to find out what the barriers were, or what their views were about quality of care that they were receiving. So it was good to see that the way that they're maturing in their quality approach and be able to apply their learning and the QI methods to new projects and new initiatives. And another example is addressing the problem of antibiotic use, to try and have more appropriate antibiotic use. And this is a good example of the way they work in Mozambique that I think we can learn from, where it's an issue identified by the Ministry of Health at a national level. And so what they want to do is to start a project in one hospital, and they've picked the Mozambique hospital. They'll undertake a QI project, and the learning from that can then be cascaded or multiplied across all hospitals. And that's an approach they're using with a lot of the quality projects. So just briefly, a couple of words on Ethiopia. Similar type of program, similar approach. We've been closely linked with the embassy on the COVID-19 response. With the QI work, what's a key feature here is that following the QI training, and this is with teams from 12 hospitals in Addis Ababa, 25 key people from the hospitals and from the Ministry of Health have engaged in the ISQA fellowship program, the one-year fellowship program. And that's provided us with a focus and a way of continuing to work with them to strengthen their capacity. And we can do this through regular webinars, and that's the way we're working with them. We work together with ISQA on that. And so that's a way that we, even without being able to travel, we're able to continue to work with them and help build capacity. A key thing has been sharing information and resources and at a distance when we can't visit. One way is sharing learning through webinars. We've worked together with the Irish Global Health Network and the ESTER Alliance to run webinars, 18 webinars since March for COVID-19 conversations. We've involved many of our partners overseas in that, including our partners in places like Mozambique and Ethiopia. And many people have had the opportunity to learn from that, both in Ireland and in other countries across Europe and in Africa. We've also been involved in training materials, and this initiative is one that we don't take credit for. This is an initiative of the Gori Malawi Health Partnership. The Malawian partners identified their desire and need for training materials to prepare their facilities to respond to COVID-19 and to deal with the challenges that they were facing with that. And so they developed 14 short training videos, and we worked with them on that and provided some support then to advertise the videos through Facebook. And they've been seen now, at the last count, more than 1.8 million times across all African countries. And so we've learned through this about the ways in which we can use social media to work at a distance with partners and still be able to share learning and to be doing training. So coming towards the end of the presentation, just keeping an eye on the time here, that just finally with lessons. What are some of the lessons? And these are general lessons about what we're learning about working with other countries, about building better health systems and health services. And it's the theme "Build Back Better" is a common theme that we hear across with our partners. And we're learning that, through the pandemic, I think what we've learned through the pandemic is really how fragile health systems are sometimes and how they're not prepared for shocks like pandemics. And really, it's put a spotlight on the need to really work harder on strengthening health systems, on the need to be better at addressing quality. Quality is so important at this time when it's become so difficult for health services to continue to provide just basic care. It's reminded us of the need really to provide the appropriate, if we're going to have good quality healthcare, it's got to be the appropriate model, the importance of primary healthcare. And we learn a lot from countries like Ethiopia and Mozambique about that, that's fundamental to providing high quality healthcare for everyone, and if we want to not leave anyone behind. So we're learning a lot of lessons for how we can better work with countries to strengthen health systems, and that learning will stand to us after the pandemic. And then lessons for quality improvement. What we've learned, I think, is that these bilateral partnerships, like we have our health service with health services in other countries, that this is an effective approach to improving the quality of care. We've also learned that virtual working can be very effective. And we're all getting very good at Zoom and everything else. And this will certainly stand to us in the future. At the same time, we can't do everything virtually. And so we're going to continue to have a blended approach. We still need to go on country visits. We missed out this year on not being able to do rural workshops in both Mozambique and Ethiopia. We want to do those, but they're complemented by working virtually at a distance. And then we're I think, recognizing just how much we can learn ourselves from some of this work with other countries. And that's a challenge. And I'm not sure how best we can address that. Right? There's so much we can learn from the countries we work with, because I think, as you've seen from the examples, very similar problems and challenges that we face. And that's really where I want to end, with the slide about that, opportunities for mutual learning. And just recently, I saw this on the left, I saw this posting about the Cork team that got a Health Service Excellence Award because of their work addressing gynecology waiting times. They're the longest in Ireland, and they reduced them from, it was something like 4 years to 12 weeks. And I thought, yeah, that's great. We all want to learn from that. And that's hopefully that through that being recognised, that other services can learn. But we can also learn from Mozambique, because there's a similar project addressing gynecology outpatient waiting times, which I've referred to. So how can we bring some of that learning back to Ireland as well? I think there's opportunities there. So maybe that's a good place to learn or to end. And I look forward to the discussion and questions that you might have. Thanks.
Great. Thanks very much, David. I'm just looking at our chat box here, And there was just some comments saying that it was very interesting when you spoke about the focus on primary care and data collection, about bringing it back to people's homes and ensuring ownership at grassroots level. So, like, what are the kind of critical success factors around that, David, about bringing it back, I suppose, to ensure ownership at a grassroots level? Are there anything that needs to be in place to do that?
Yeah, I mean, I think there's a couple of things I'd say in connection with that. One is that it's not enough just to have strong leadership capacity and quality at the national level. That needs to be you need to have that also at the local level. Mm-hmm. And in the case of local services, that might be the local hospital. And if they're going to really be able to address things, they need to be empowered and enabled to address their own issues. And that's about giving them the capacity to be able to do it. And I think for us, when the learning through Mozambique was that what was really important was to identify key people in the hospital who would be leaders and champions for quality in their hospital, who would have that local leadership, and then that they would inspire and motivate others. And we saw that when we visited, how they were then inspiring others to get involved. And it was very much owned locally. And they celebrated their successes. And in one part of the hospital saw the success of the project, others wanted to do it. And it was very much recognized as their project, their initiative. So when we worked with them, we didn't say, well, your quality project should be on waiting times. No, we said, you identify what your issue is, and then work with them on that. And then that needs to extend then, I think, like you're saying about grassroots, it does need to extend also to community level and have that community ownership. And that's partly about a commitment to primary healthcare and a recognition of the importance that families and communities play in their own healthcare. And I think we've a lot to learn about that in Ireland, but these other countries have maybe recognized that more out of need. And during the pandemic, it's been shown, I think, even more so to be important, where you have the need at a local level for people to be informed about COVID-19. There's a lot of misinformation. People aren't attending for healthcare because of fears, and that needs to be addressed. And just for able to work with Meg for supporting people to address their healthcare needs and to avail of the healthcare that's available in an appropriate way.
Okay. And another question is around, are there any links with the IHI in the USA, David? Have you been bringing in any of their work into the work that you do?
Yeah, I mean, the IHI is another very important global organization that's involved in very similar work to what we're doing. They're working in countries. They're also working in some of the same countries. And IHI has been very active in Ethiopia. So we see them very much as we're partners in this, where we've similar objectives. And so our work is very similar. It's complementary to what they're doing. So in the case of Ethiopia, where IHI has been working, we've been very careful to reach out to them to find out what they're doing and to work in a complementary way. And a lot of IHI's work has been at the district level and community level. And so it's worked well for us to come in and work with the hospitals, because that's an area of unmet need.
Great.
We have worked with the ministry to help them develop their strategy and training materials. So we haven't tried to come in with a different approach. We've worked with the same training materials. So not, to work as a unified approach. So I think it's important to work in a complementary way and coordinate, not to work.
Thanks, David. And I have another question, just asking you to speak a little bit more about community health programmes and person-centred care. Any learnings for us here in Ireland with regard to that?
One of the things that has frequently struck me with both Ethiopia and Mozambique is how often they will bring up the patient in discussions about quality of healthcare. And I think, we all know kind of historically, a lot of quality in healthcare has been driven by the professional perspective. And we have our own, as health professionals, our own ideas of what good quality care looks like. And it just too often we lose sight of the patient in it, that care can be technically very good, but not very friendly to the patient. And I think it's just about just keep reminding ourselves of that it's all about the patient, and that if we provide good technical care, but the patient experience is not a good one, then that's not good quality care. It may be safe at some level, but it's not, in an overall sense, good quality care. So I think it's about that appreciating that, and that for instance, Mozambique and in Ethiopia, you'll see at the national level in their national strategies for the health service and for quality, the patient is frequently mentioned, that it's about person-centered care. And so then that filters down, and then you hear it. You hear the hospital, the leaders in the hospitals and the staff in the hospitals talking about, oh, we need to be thinking of the patient and we need to engage the patient. And they are quite good in those countries at having mechanisms in hospitals for hearing the patients, listening to the patients. They sometimes have patient liaison staff whose job it is to meet patients and to hear from them about what are their issues, if they're complaints and that sort of thing. So it's maybe it's a cultural issue. It's part of just the way and their understanding of quality. Quality is all about the patient's experience, how the patient experience care. And the project I mentioned at the end about the older people in Matalani, how the care was there for them, but as older people they weren't able to access it well, because they come to the hospital and there were very long queues and they weren't able to stand in queues and they were treated just the same as everybody else. And they found it all quite difficult, and they weren't having good experience of the way they've been treated by the health professionals. And so it was out of I think, an appreciation that that's really important, that led them to undertake the project to address that and to hear from the patients. And it's always often interesting how when you ask professionals about the quality of care, they have a different view than the patients. They think it's good quality and the patients don't. And so you just need to hear from the patients and listen and have ways to hear their voices so that you provide care that is what they want, not just what technically good from your point of view.
Okay, and I have another question around the provision of training virtually, and I suppose we've moved into that zone now here. Can I just ask you what worked well with regard to the provision of training? Did you do a lot of training online, David?
Yeah, I think, well, the first thing to say about working virtually is it does allow you to engage more people sometimes and more frequently. So if we're going to do things face to face, we have to visit a country. How often can we do that? Maybe once a year, maybe twice a year. Virtually, we can do every month. So it allows for much more frequent engagement. And if a lot of learning is by coaching and by that one-to-one interaction with people, we can do that more frequently online. Now, in order for that to work, it helps to establish good relationships with the people we're working with. So I think we're able to do that well online because we've been out to these countries, we've met the partners, we've worked with them, we understand them, we know where they're coming from. And then we can have the discussions online in a meaningful way, where we're not just talking theory, we understand, we know the realities of what they're working in, of working with. And we find, the Zoom is very good. We use Zoom a lot because that's what the platform that they have easy access to, but there's other platforms that are work well as well. They're able to come on wherever they're working. They don't need to even congregate in the same place. Even if they're working in different hospitals, they can come on from their different locations. And of course, Zoom and these platforms allow them to share presentations. So they can come on, they can do their PowerPoint presentations, take us through them, and then we can have discussion about them. So it's a lot less limiting than we might have thought at the beginning when we started doing it. And we're having some very, very good discussions under the fellowship program with the Ethiopian learning sets, where we're having very good engagement where we're sharing articles with them. The ISQUIS shares articles with them, and then they come on and we have discussion. They share back what they've learned, and we have discussions around it. And it can be maybe as effective as we might do if we were doing it face to face.
Great. And just finally, I have just two more quick questions, David. One is in relation to leadership. And the comment was, it's very interesting to hear how you've engaged in partnership co-designed, and how leadership works at a local level. How do you encourage leadership development and support?
Well, I mean, for us, it's been firstly trying to find the leaders, because the leaders they're there. And in Mozambique, we signed an agreement in 2014. We didn't start technical work for 2 years because we didn't know who the leaders were. We didn't find them. We didn't find people who wanted to take charge of and take a lead on addressing quality improvement issues in their health service. And it was when the doctor I mentioned, Elenia, was appointed in charge of hospitals, and she came to us and said, I'm concerned about quality of care in hospitals. I want to address it. I want to address it to our collaboration. And so it was the leader coming forward that then gave us the person to work with. And as more people came in, it was about identifying who the leaders were in the hospitals. Who were the people that, if we worked with them and trained them and helped build up their capacity, would take that and lead work in their own hospitals. So firstly, it's about finding those people, and then it's supporting them to be better leaders and motivating them, and it's both challenging them and motivating them. And I was always very impressed with Dr. Eleni in Mozambique, how she constantly challenges the leaders in the hospitals to work better, but also supports them and encourages them and acknowledges when they do things well. So I think that's important, is celebrating success, acknowledging achievement, and just encouraging people when they are doing well to be inspired to keep leading. And then I think it's also understanding what is a leader, and that's part of then to bring that into the training. It's not just about looking on quality issues, it's also about the leadership for quality and what makes a good leader. And that's something then that we will reflect on in the coaching sessions, is what's the difference between a leader and a manager, and how does it express itself of being a leader? When we had an example just from our webinar in the last couple of days of talking about walkarounds in hospitals and the role of the leader, and the role that you need to listen, not to come in as the manager and inspect, and just understand what the leader is doing that's different to be able to lead quality in their hospitals.
Great. And finally, David, just one question, and I suppose it does link in with the leadership side of things around how do you identify projects? How do you support the organisations when they're identifying their projects to work on? And are there times when projects may not be viable? And so how do you support them to identify their goals?
I think we didn't find this a particular difficulty, and I think the hospitals were well able to identify a number of issues of concern of quality. But what we encourage them is first of all, I think with the teams from the hospitals, we didn't just want a team from one ward. We want a team that maybe of people working at the front line, but also people who are in senior positions in the hospital who could reflect what some of the key priorities for the hospital as a whole were. And then it's to have that kind of shared agreement in the hospitals that these are some of the priority issues that the hospital wants to address. So it's already their priority, so they'll want to work on it. Now, the question of whether it's viable, I mean, one of the things that we learned so much from our partners is that they keep telling us how they can improve what they do without extra resources. They already have tiny amounts of resources to work with. And of course, they know they're not going to get any more, and they know we don't bring any extra resources financially. But they are very much appreciating that you can always do better with what you've got. So we've not seen projects not being viable. The project is always viable because you can do better with the resources you've got. A lot of QI work is about better use of existing resources. And I think when you have very scarce resources in the first place, sometimes maybe you're more resourceful. So we've not seen that as a problem, viability being a problem. I think it is about more wider things like just the general capacity within the hospitals. Sometimes I think if hospitals are just really struggling generally to provide services, and if they're under-resourced, particularly if they're in remote areas and not well supported, I think in those cases it's a bit harder. And sometimes morale might be low, and it might be hard for people to say, well, how can we improve quality when we don't have running water, and we don't have electricity, and we we don't have drug supply and all these things, and we don't have working equipment. So yeah, it's very challenging. But nonetheless, we've found people who don't see the problem, they see the solution. They see how things can be done better and want to make a difference, want to improve things. And so it's always possible to improve. That's something we would say definitely from working in these countries. It's not about resources, it's more about the will to do things and what they want to do, and then they own it.
That's great. Well, thanks very much, David. I think I've managed to pick up the comments in the chat box, and thank you so much for your very interesting presentation. And we hope to probably touch base with you maybe later on in the year of next year in relation to see how you're getting on. So thanks so much for that, and thanks to everybody for their comments and their participation today. So just moving on, just slightly, we just thought we'd just share with you some of the next few talk times over the next couple of months. So our next one is around managing open disclosure on the 3rd of November. So we're hoping that you'll all log in for that. We're looking forward to seeing you then. It'll be Angela Teisel, the lead for open disclosure, will be leading out on that webinar. So thanks again to you, David, for your excellent presentation, and to Naomi in the background and making sure everything works well. And looking forward to seeing you all on the 3rd of November. And thanks very much to you all. Bye. Thank you.